thank you very much for this opportunity to tell you a little bit about how we are working in Reykjavik, in Iceland actually, because Reykjavik is the leading community that is working with homelessness in Iceland. My name is Heiða Björg Hilmisdóttir and I'm the chair for the Welfare Committee. I'm also the vice chairman for the Social Democratic Party in Iceland. So I'm a politician and I've been really interested in this topic for a long time. So it is an honor to be able to work with it and to have influence on how we are working with homelessness in Reykjavik. As you see here, this is our beautiful country, and Reykjavik is 1/3 of the population of the country. We are by far the biggest city in Iceland. Still, we are a quite small city if we compare to any other cities. So in many ways, maybe it's harder to hide in Reykjavik as a homeless person than in many other, at least capital cities in the northern countries. But the whole capital area is like 2/3 of the population, but the area is just 1% of the whole country. So we are tied together here in Iceland. But we have 69 municipalities around the island, and some of them maybe just have 80 people living there. So we are experiencing that a lot of homeless people, they move to Reykjavik to get the service they need and have the right to have. Before I maybe tell you more about this, this is how we have been defining homelessness in Iceland. We have just used these 6 of 13 ethos definitions. We have been looking at these living rough, emergency accommodation, those who are living in the women's shelter, just going to be released from institutions, long-term support and insecure accommodation. Of course, we could use more of those ethos definitions, but this is what we have been measuring here in Iceland. And we have not been working for so long with this. We just started like 2014. Measuring how many people there are in Iceland that are homeless, and we have been focusing on the capital area or the Reykjavik area. And in the beginning, we thought, we estimated that it was around 45-55 persons in 2014-2015, and only 5 women. And then we made this again 2009. And then the amount had doubled. 2012, we also made this estimation. And then we had 180 persons almost, and a lot of people from Poland, Polish citizens, were then recognized as homeless in Reykjavik. And we did this again, 2017, and the amount of people living homeless in Reykjavik had again doubled. So we had to do something about this, more radical than we had been doing before. We made this strategy 2008 about the first strategy about how we were going to do this. Of course, we had shelters before, we had some service before, but we had no strategy or policy about how we are going to work with this group of people. So we were mostly focusing on those shelters, how we were going to run those in 2008 and 2012. We were supporting the halfway houses, and we maybe mostly focusing on those who are living rough. And we made this team that went out to the city and helped those people that were on the street to find the housing or those places they could stay for the night. The next time we made this strategy was 2014. Then we put the human rights in foreground, and I think that was a really big and important step for us. We also put the housing policies for homeless people. We included that in the housing policy for the city. So this is not now a special housing policy, it's just a part of the big policy for the Reykjavik city. And we also, we increased the cooperation with others and trust in the mobile harm reduction needle exchange program. So even though the policy did not talk really about harm reduction, we started to work with that. And it was actually 2015 that we started working quite openly about that we wanted to implement Housing First and housing and harm reduction in a more precise way, even though our policy didn't really maybe talk about that. And we continued with our outreach team, and it evolved. And Hrafnhildur is going to tell you a lot more about that, because she is working with that team and in charge of that. So now it meets like the ICM definition, but then we started to like try to get it to meet that definition. So it was actually really important that we would make a new policy in 2018. We saw in the 2017 numbers that the amount of people homeless in Iceland were doubling continuously, and we had to do something new. So we put we have the housing, we have the human rights as a core goal in the city, and in all that we are doing in the city, we have this human rights always as a goal. But in this current policy, we have the housing first as a goal. So we want to be able to offer those homeless in the city housing that they can call theirs. Just not even we have opened one more shelter for homeless young people, homeless people who use drugs, but we want them to be able to have their own home. So we have been focusing a lot on that and increasing the housing opportunities. Of course, that costs money, but this is a good investment in our eyes. We also have been focusing more on women's hidden homelessness, because we didn't really recognize in the beginning that so many women were homeless. Of course, we have this women's shelter and domestic violence and that as a cause for homelessness, but we didn't really see all those women who are homeless and maybe living in where they don't want to live and don't have their own home or their own things with them. So this is our focus now, and we have opened one home for women who are homeless, and we have one temporary home where we are trying to find more permanent solutions for those who are there now. We also hired specialist staff to work with the ICM team to evolve that even further and educate both ourselves, maybe in the beginning, our staff and the nation really about harm reduction and how we are going to work with this and why it is important to work with this. Because earlier we had more been like, we can help you when you stop this or stop that, or if you do this, we will help you. But now it's more like we want to meet you where you are. We care about you, and we want that this period will not do you more harm than it's, Mostly, we would of course want it to do you no harm, but to reduce the harm that this period in your life is doing to you. And to the community and your family and all others. We have been also reaching out for more cooperation between other local communities. We have been reaching out to the state in Iceland, to the social Minister of Social Affairs, because it's important that we do this together And we see that people move to Reykjavik because they want service, and we want to be able to offer that as a capital city. And I know probably other capital cities are experiencing the same. So we have now really gotten some steps ahead. We have more cooperation with the state now, both with the Health Ministry and the Social Affairs Ministry. So, Hrafnhildur, do you want to take over now?
Yes, thank you. Thank you, Heiða. It was good in the presentation. Thank you for having me. And I want to say I'm very honored being asked to participate in a conference regarding the subject that I'm dedicating my working life to. And congratulations for this important conference. I hope you're all well. First of all, I want to mention that if anybody wants my contact information, I would gladly answer questions after the conference if we don't have much time after this. Also, if anybody just wants to share experience or talk about cooperation, I would be happy to discuss that online. But a little bit about me. I'm a psychiatric nurse with a background in emergency and trauma, caring for people with infectious diseases, psychiatric inward and psychiatric acute care. I'm the first team leader hired for Reykjavik's outreach team in November 2018. And a few months later, I was hired to be head of this new department to supervise all Reykjavik's municipality homelessness services and implementing housing first and harm reduction, as Heiða said, in Reykjavik's municipality services. At the same time I was hired, the Reykjavik's Committee of Welfare was in the midst of preparing our new policy. So I got the opportunity to participate in the final sprint. First and foremost, I decided to ask the committee for the ethos table being translated, all 13 definitions. And we contacted FEANZA, and they were very positive and helpful. Since then, the municipality have followed FEANZA guidelines regarding services, especially in the pandemic. The other thing I thought was very important to start with was about the outreach team, who then met most criteria of ICM team, intensive case management. And it was regarding evidence-based information. I wanted them to broaden their outreach and take on more people that weren't necessarily defined roofless or houseless, and that the team would service them, especially focusing on women dealing with hidden homelessness. The criteria for getting this ICM service is having a history of struggling with homelessness for a long time and having comorbid disorders and highly complex needs. Most of our users have severe substance use problem, and most of our users have great traumas in the past, childhood traumas and so on. So we're really focusing on safe space interventions. I'm happy to tell you that from that time until now, we have multiplied how many people are getting ICM service. And best of all, we now continue servicing people, though they get admitted to hospitals, treatment facilities, are present, living under domestic violence, and so on. After these changes, the number of women getting ICM service that are roofless, living in insecure accommodations, or living under the threat of violence, they multiplied from 4 to 19 within a year. From March this year until October, the number went from 19 to 32. Thanks to outreach, the Reykjavik municipality and the Ministry of Social Affairs, we opened a temporary shelter for women with severe substance use problems that were seeking service and living in violent situations. It was getting worse and worse as the COVID-19 pandemic extended. Another thing especially worth mentioning is that no inmates were getting ICM service in 2019. And now in October this year, there were 16 inmates getting ICM service. All of them met the criteria. Same as for people living in insecure housing. There were none getting service in 2019. And in October this year, the total was 10 people. And finally, it's also worth mentioning that the total number of people getting ICM service went from 49 in February 2019 to 108 in March this year. And due to the pandemic, probably the number has increased rapidly. In October, we had 153 people meeting the service criteria. Obviously, we needed to hire more people temporarily in the ICM team. And this slide is just to show you how rapidly the municipality cost of homelessness service has grown since 2010. It's very rapid, as you see. In Iceland, there has been a battle of whether homelessness is mostly a healthcare problem, combined social and healthcare problem, or just on the responsibility of the social system. There's been a great progress, and now we are in the midst of the healthcare problem is finally recognized of the government. Just right before COVID, our Ministry of Health published a report with suggestions regarding homeless people with comorbid disorders, dual diagnosis, and therefore recognizing imminent need for actions regarding healthcare, such as nursing homes, general health clinics, specialized harm reduction hospital spaces, and more. Their main findings was, as in Reykjavik policies through the years, that Iceland need to set a policy regarding homelessness and housing first, and recognized the need for cooperating committee, that is governmental, municipality, and NGOs. I'm proud to say that Iceland is preparing to open their first safe consumption site, and the Ministry of Health has a bill to amend the law to legislate such operation. Next slide, please. Here's a slide just to graphically present the rapid growth of how many homeless people are getting ICM service. And on the next slide, you can see statistics of 2 time periods, one for each year, 2018 to 2019, and then 2019 and 2020. This shows that both emergency visits and admissions have decreased, but at the same time, more individuals are seeking emergencies and admissions. These are only our ICM users. And on the next slide, you can see how many emergency calls and ambulance transfers in our shelters have decreased significantly at the same time periods. These numbers are only for ICM users. And if you compare the rapid growth of people getting ICM help, you can imagine how much more success you could read from these slides. I just don't have the statistic for it. We want to establish a ACT team cooperating with the ICM team because of the healthcare needs in shelters and for our users in general, especially regarding psychiatric care, maintenance treatment, HIV and hepatitis C diagnosis and treatment. We now have 2 nurses working with the ICT team. You can just imagine how full their schedule is. The conditions for getting the nurse's assistant regarding maintenance treatment, HIV, hepatitis C treatment, the individual has to openly accept service. And there is an absolute requirement that they are admitted in an outpatient treatment or have a guaranteed physician responsible for the treatment. That means that our nurses and other team members need to be highly resourceful and willing to think out of the box to help our users to get the medical treatment that they need and want. There's a lot of pressure that follows that kind of work. People who have studied the Housing First Way and ACT teams, they know how cost-effective an outreach medical service is for this marginalized group, especially for hospitals and emergency care. So I'm just waiting for the government to plan on ACT care for our users. We have the nurses, social workers, and other important professions. We just need the doctors and the layout. And on the next slide, you can see the rapid growth of a number of women getting the ICM service. Though this doesn't mean that homeless women are multiplying, this means that more of them who are homeless, according to Ethos, the whole table, are getting service. They're being recognized, and most important, more women are being housed either in our long-term facilities or scattered housings. And on the next slide, for the final part of our workshop, we want to tell you a little bit about both the shelters and the housing Reykjavik's municipality welfare system has to offer. We are aiming to get to that point that we don't need shelters anymore, and we can change them to facilities like in Finland, but we are still trying to reach people experiencing hidden homelessness, mostly women, and we need more research and much more governmental support and policies to get to the same place like in other exemplary countries regarding housing first. Though we can be proud of our evidence-based progress for the last few years and how that really prepared us for the pandemic like COVID-19, the whole country needs to do much better regarding evidence-based future plans. And on the next slide, the purpose of this workshop was to talk about, the small population and advantages and disadvantages. To mention that some of the advantages are our possibility to have a clear overview and cooperation between institutions and NGOs. We can have a very tight network here. We have the possibility to ensure that no one sleeps outdoors, for example, in times of extreme weather. We open our shelters around the clock, and we have a cooperation with other services providers, the Red Cross and NGOs and police and emergency departments. And we have the option to find if there is anyone sleeping outside or in imminent need of help. That's very special for us. Our ICM team has an extra outreach responsibility and can quickly respond if necessary. Because of our small size, we're in good position to have a tight network and solidarity among people working in the field. We can also implement evidence-based knowledge simultaneously in our service. For example, we have a high rate of people using IV substances, and just in a few months, we were able to implement harm reduction needle exchange service in all our services. In order to do this, we got a great help from the Red Cross mobile needle exchange service and their specialists. To talk about disadvantages of small population, it can be that we have a smaller healthcare system, therefore fewer specialized options, and in some cases there are relatively few people with certain complex diseases or disorders dealing with the same problem, and therefore it's difficult to develop specialization and service and housing. And on the next slide, for the challenges. The challenges that we have been facing is public opinion, sadly. It's still in progress, but it has been an obstacle regarding putting up housing. There has been some kind of opposition against Housing First. That is clearly just because of lack of knowledge or acknowledgement and education. We still have work to do about the health clinics. There's a lack of training and education in this field. You can't go to health clinic against maintenance treatment. There's a system here that demands you to do a treatment first and get the maintenance treatment from addiction rehabilitation center or our hospital psychiatric treatment. So there are many obstacles there. There's also a severe lack of access to naloxone, like nasal sprays. They are both prescription required and expensive. Our police and mobile needle exchange services and the Reykjavik ICM team, they don't have clear access to naloxone. There has been skepticism about harm reduction and misunderstanding that using this ideology, you keep people in their situation and prevent them from rehabilitation. There's also been vocabulary challenges because we have been using a word for homelessness that means houseless. In English, they have roofless, houseless, homeless, and homelessness. We are trying to practice this in Icelandic so people have the same understanding of what it is what. There has also been very difficult to protect the privacy of the residents in tiny houses, especially, and houses we provide in general. And then I'm talking about protect them against the public or neighbors and media. And for the final slide, what we have implemented and done to meet the challenges. We use every opportunity to educate, and we follow media coverage and correct misunderstandings when they arise and correct marginalized phrasing. We give interviews when given the chance, and we try to keep our website up to date. Last but not least, I'm glad to inform you that there has been an increase in people getting the service. They are speaking up. Last summer, a few women who are staying at our temporary shelter, they spoke up and gave interviews. the media or press. I think that has given people perspective, and it fights marginalization. And to end this, I put a final slide to, no, nothing. This is great. Thank you.
Yeah, thank you, Hrafnhildur. I think this is maybe the main goal now. It's to educate the nation and the people in Iceland, and especially in Reykjavik, that we have to offer services and we have to find a way to live here together in this community. We are different. No one is like the other, but we all have to have our place. And I think that is, we have been having a lot of help from the Red Cross, but we need more NGOs and we need more help from the society, but I think we are getting there. I also want to say, because this is a Nordic meeting, that we have been looking a lot to Finland about the Housing First strategy and how we are going to implement that. And we have also been looking a lot to Denmark about the tiny houses and how you have been doing in Aarhus, and also to the other Nordic countries. So even though we have not been able to travel to you, we have had Finnish guests here, and we have been following you in your work also. So thank you so much for inviting us to tell you about this.